Hello, everyone. Today we're going to be talking about what is pelvic floor physical therapy. So, I don't have one particular person asking about it, but what I do hear is this question often. So, when I say I'm an orthopedic and pelvic floor physical therapist, either people have heard of it or they haven't. And if they haven't, then a lot of people assume, actually, even if they've heard of it, they assume, oh, this is really only due to pregnancy or people that are postpartum. When the reality is that's not true. You hear about it more in those populations, but everybody with a pelvis has a pelvic floor. So, what that means is there are muscle groups, there's pelvic organs in there. A lot of people can have pelvic floor dysfunctions and just not even be aware of it. That's why I wanted to come in and say, hey, it's not just for pregnant people and it's not just for women. People with penises, they can benefit from pelvic floor physical therapy as well. So some of their common symptoms can be erectile dysfunction, delayed ejaculation, pain with ejaculation, pain with penetrative sex as well, inability to maintain an erection. There's a variety of different things that can happen. Those are sexual side effects. There's pain as well, and a variety of other symptoms. But for women or people with vulvas, a lot of common symptoms can be constipation, it can be pelvic heaviness, it can be pelvic pain, it can be repeated hip flexor pain, low back pain that hasn't improved. It can be prolapse, it can be pain with sex, pain with penetrative sex, pain with an orgasm, inability to orgasm, or changes in orgasm, repeated yeast infections, repeated UTIs. You name it, there's a lot of things that we can do to help. We can also help with endometriosis. There's more research coming out on infertility. This past weekend, I went to Pelvicon and there was a specialist there talking about how pelvic floor physical therapy can affect infertility. So there's just a variety of things that we can do. Another thing actually is hysterectomies. Having a hysterectomy, a lot of people aren't sent to pelvic floor physical therapy after when there is a removal of an organ and there was a major surgery, right? When I say major, it can still be laparoscopic, but it's still surgery to remove an organ. So PT for that can be helpful. Diastases recti, so that's separation in the abdomen. Also cosmetic surgeries like tummy tucks as well. And after having breast cancer or any type of cancer can affect the pelvic floor. So I won't go into the specific treatments for each of those things because that's basically what I've done over the past, a few podcasts as I've talked about different things. But what I wanted to do is basically walk you through what to expect when you go to a pelvic floor physical therapist. I'll give you an example for us. So when you first come to Resilient RX, what will happen is we have people fill out an intake form. And in that intake form, there's a variety of different questions, including your past medical history, OBGYN history, your surgical history, past medical history, any familiar history, just so we can get an idea before we start an assessment of what is going on. So what are your goals? What are your activity levels? What are things that you would like to do that you're not doing because of leakage or pain or whatever it may be? So that way we can look at you as a whole, right? And so when we do an assessment, it can be internal or it can be external. So I want to clarify. I know a lot of people may be scared of pelvic floor physical therapy because there is an intravaginal assessment where that's an index finger goes intravaginally and assesses the muscles and the strength and the scar mobility. But it's totally okay if you don't want to do that. So what I find is that people tend to be scared or they'll avoid it because of that part. But you have the right to choose not to do that. Even if you give consent initially, you have the choice to revoke that consent at any time. So people will give us verbal and written consent for an internal assessment. What the internal assessment looks like is I'll have the patient disrobe from the waist down. I'll step out and have them change. We put a pad down on the bed and then a sheet over top so they'll lay on your back. Okay? Then from here, we'll talk you through it, but we look at the vulva and just spreading apart the labia. We're looking at the vaginal opening, the tissues. Are they red? Are they white? Are they tender? No. What's going on around the tissues? Because what I do find a lot is either the tissues are a little bit more red or irritated, and that gives me some information. The other part is sometimes the color can be a little bit more pale. Sometimes that can tell me, oh, well, maybe there's a change in estrogen here. With the redness or irritation, what that tells me is the tissue's irritated. It doesn't tell me why, but it's just another piece to the puzzle. So that's generally looking at it from externally or from the outside, right? So if we're just looking at the tissues. And then you can see the area between the anus and the vagina. So that's the perineal body. And then the anus is a bit further back. But if it's mainly for intravaginal assessment, these are things that we're going to be looking at. So the next part of the assessment would be having the patient will insert a finger and push down on the vaginal opening and have the patient bear down like they're having a bowel movement. Essentially what this is doing is it's showing me if you have prolapse. So that's when the bladder or rectum, the most common organs to prolapse, see, hey, is this part of the symptom? And then we'll pull up and have you bear down as well. That will give us an idea as well. Then the next part would be feeling the muscles. So, hey, is this tender? Is this tender? Going intravaginally with an index finger and palpating the muscles to see if there's any tenderness or tightness as well. Then with that, we'll have the patient contract and relax. We want to get an idea of the strength. And then to get an idea of the coordination endurance, it's more of, okay, how long can they hold this for before the muscle starts quivering, right? You might have a really strong contraction, but if you can't hold it very long, to me, that tells me it's an endurance issue versus if you can't contract, is it an issue where we've dissociated from the pelvis? So sometimes that can happen where have just ignored the entire pelvis since a traumatic birth with unfortunate experiences of sexual assault. Sometimes that can happen. Purity culture, a lot of different things can cause us to disassociate from that area and just be like, I'm not even thinking about it. But the reality is it is a part of your body. And there's ways that we can ease into getting you to reassociate yourself with your pelvis and with your vulva. But my point is that with that, your muscle, if it's not contracting as well, is it because the muscle in and of itself is weak? Is it because the muscle's too tight that it can't contract as well? Or is it because the connection from our brain to our pelvic floor is impaired? So it's not allowing us to really contract and relax. And so sometimes it's just the repetition of getting that and just improving the pathway from the brain to the pelvic floor to get those muscles more activated. But it's important to note that that's just the internal assessment. What I do find, unfortunately, is that is where most pelvic floor physical therapists stay. I do find that this is actually a disservice because the pelvis is a part of a human. And of that human, there's different body parts, there's different life experiences, there's different lifestyles, there's a lot going on, right? So your pelvis is connected to your hips, which is connected to your knees, which is connected to your ankles. It reminds me of that song. What was it? The ankle bone's connected to the knee bone or whatever. I don't remember the exact names, but I remember when I was going to PT school, my college girlfriends would sing that song to me. I was like, yeah, why do I even need to go to PT school? We've got a song that tells me everything about my body parts. But anyways, so it is all connected. So if the next part of the assessment is, how are you walking? Like, let me just watch you walk. What I'm looking for when somebody's walking is, are they swinging their arms? Is their thoracic spine rotating? How are they landing? Are they fully striding one foot in front of the other, or are they limping? What's going on around that? Sometimes I'll actually do a slow-mo if I see something, but I need it to slow down quite a bit. I'll do a slow-mo video and take a look at how they're walking. Walking can tell you a lot of different things about a person's posture, their how they're moving, and different compensations that can occur over time. We can see in how somebody's walking. So the next thing would be to look at how your balance is. So standing on one leg on both sides, right? So one leg, your left leg, and then your right leg. Then how are you with dynamic single leg stability? So standing on one leg and reaching forward, are you able to maintain that control? One of the biggest things that I'm looking for in that is what they're doing with their feet, because I've talked about this before, but the feet are closely related to the pelvic floor and the brain. So engaging the feet in a way that activates the whole foot, not just part of it, can make a big difference. For example, I see this very common where people put a lot of their weight in their heel and almost no pressure in their toes. That can set off your balance, because if you're not using your toes to help grip the floor, your balance is going to be off. So it's important that I'm looking at, when they're doing balance, right? Are they keeping their big toe, their little toe, and their heel all in equal contact with the floor? I'll also look at this with squatting. So I'll have somebody squat because it's a very functional movement. I see a lot of putting weight into the heels and squatting down, because back in the day, we used to say, put your weight in your heels, put the weight in the heels. But what that does is that almost makes you fall backwards. When you do that, you're not engaging the front part of your pelvic floor as efficiently, or the front part of your thighs, and on and on. So you can even try it at home. Stand up, put more weight in your heel, and squat down. And then repeat. Stand up, put a little bit more weight in your forefoot, and squat down. You will feel a different set of muscle groups activating when you're doing those activities. So if you are not putting more pressure on your forefoot, what happens is, if we don't put as much pressure on our forefoot, if we lean forward, that helps us engage the front part of our pelvic floor a bit more. So that's around the urethra, which, when the muscles around one of the bigger muscles around the urethra contracts, it helps us stop the flow of urine. So that's why body movement and how we're moving and how we're walking can directly affect the pelvic floor. Also, if your ankles are stiff and you're squatting down, your knees are rolling in, that can cause your femur to roll in, which then can affect your pelvic floor muscles, because those are connected to the pelvis, and the femur is connected to the pelvis as well. So that can affect everything all the way up the chain. Another thing I'll look at is hopping. So say, how are you able to hop? Like just jumping in place, like kind of like almost like you're doing a jump rope. You could do that, and just kind of seeing how they're landing, how they're feeling, especially if they're saying they're leaking when they jump. I won't have them jump if they know they're going to leak and maybe they don't have a pad or they don't feel comfortable doing it. But generally speaking, we're trying to get an idea of why the symptoms are occurring outside of just the pelvis and the pelvic floor. Just pelvic floor muscles being tight doesn't tell me much. It tells me that a muscle is tight, but I don't know why. If we stay just in the pelvic floor, I know there's a lot of people doing internal assessments and internal treatments for a majority of treatment. What this does is it releases muscles, but it doesn't address why. Yes, we will do that in treatment sometimes, but that is not the sole focus. The sole focus is, why are these tight in the first place? And why do they keep getting tight? Because the reality is, going into pelvic floor physical therapy and constantly having those muscles released, it may help for a little bit, but we're not addressing the cause. It would just be like, if you have chronic back pain and you keep going and getting massages and they feel better, but it comes back. Well, it might be that maybe you need to do rehab with it to see why that keeps happening, because otherwise it's a cycle of repeatedly going in, and then the control is removed from you and your body, and it's in somebody else's hands. So if you learn about why your symptoms are occurring, you can learn a ton of information about your body and then adjust and make things better for yourself, if that makes sense. So that's why it's important that we look at it overall. So that's some observational movements, right? This is kind of just a general idea. The next observation thing I'll do is if they have a pain with running or they have issues with running, a leakage or pain or heaviness, whatever it may be, I want to see them run. Because if that is the reason they're coming into the clinic, it's really important that we look at how they're running. The most common thing I'll see is almost overstriding. So their foot will go so far in front that they almost have to propel themselves forward and then land on the other foot. So sometimes when that happens, right, we're landing more on the heel and not engaging as much of the forefoot like we talked about before. And that can potentially limit some pelvic floor activation. But if you've never had pelvic floor issues with running and maybe your running form isn't spot on perfect like they show, in research or whatever it is, then I'm not going to adjust it because you've been fine with it and you feel fine with it. You're not having any pain or discomfort. So likelihood that person may not be in the clinic. But the point is you can go down and adjust the nitty gritty to the point where then people aren't even moving. I don't want that to happen either. It's just more of, okay, if they're leaking while running, I want to see how they're moving, right? And the other thing to look at too is how their thoracics, so they're, like I said with walking, are they rotating? So a lot of walking should be almost propelling forward. It is propelling forward, so is running. We need that thoracic spine to move. The thoracic spine is meant for rotation. That's the way the joints are lined up. The lumbar spine is mainly for bending and extending. So if you have tight thoracic spine and it's limiting your movement, but your lumbar spine is moving, but it's mainly bending and extending, and we have a little bit of rotation, you could see how maybe that could cause some low back or pelvic pain because a lot more pressure is being put down the chain because of stiffness higher up. I actually see this. This is actually one big thing that I find is helpful in pubic symphysis dysfunction is if we are tight here, it puts more stress on the pelvis. Then the pelvis has to tend to overcompensate more. And that's when we can kind of get that groin pain or pain along the pubic symphysis, which not often, it occurs more often in people that are pregnant. So again, thoracic spine is huge, in my opinion, and looking at pelvic floor symptoms. The next thing too is just different movements. So maybe if they have pain while they're squatting, doing a back squat with a barbell, or maybe they have pain while they're doing deadlifts with a barbell, or maybe they're doing it with a kettlebell or no weight at all. I want to see, we can look at the form and see what's going on there. That's why it's important to have a gym as a pelvic floor physical therapist, not just internal treatments. When we have a gym, we can access, let's see how this person's moving with this weight because they have pain with these symptoms. Or what is the exact movement so we can help direct them more. Our business model it's getting people better faster. So we try to get the turnaround pretty fast because we know that, hey, we're out of network with insurance, so it can get a bit more pricey. But not only that, you're learning a lot about your body that will basically what you're doing is you're investing in your body long term. Yes, if we just did soft tissue treatments over and over and over, that may feel good for a short period of time, but ethically, I feel it is a disservice to people if they're not learning about their bodies and just thinking that their pelvic floor is tight. So there's so much more that we can do as physical therapists to help this patient population. And we tend to put them into the activities that cause their symptoms. Obviously, if they're in a significant amount of pain, I'm not going to have them run or jump rope or do anything like that. We want to meet them where they're at, right? So if your goal is, hey, I don't want to run, but I want to get back to lifting weights and I want to get back to walking occasionally. Okay, well, let's do that. Right? I think the shame and guilt need to be removed on what we think people should or shouldn't be doing. But also, obviously, physical activity is important. So what can we help people get back to that A, they like to do, and then B, that makes them feel good, and C, how can we do that in a way that feels good in their bodies? Looking at those specific movements in and of themselves. But the next things are going to be looking at hip mobility, ankle mobility, your nerve tension. So basically the nerves that come out of the back and into the legs, how are those moving? That's usually a straight leg raise test. So you lay on your back, lift your legs up, and then flex the toes forward versus point them. If they're flexed forward and you have increased symptoms, it's usually nerve tension. If it decreases when the toe is pointed, it usually means that it's more of that nerve tension. So looking at that is important as well. Gives us an idea of, hey, how are the nerves running out of the pelvis? Are they symptomatic? Is this reproducing your symptoms? What does that look like, right? So that is a general kind of quick review of what that looks like. The next part will also be looking at abdominal mobility. So how's the diaphragm moving? So like basically the base of the ribs in the front. Has all that fascia moving? How is there any soreness along the abdomen? How are the scars moving in the abdomen? How are you able to contract your abdomen? Do you know how to contract your deeper abdominal muscles? How are your scars moving? Did anybody teach you how to move your C-section scar, your appendectomy scar, your laparoscopic scar, any of those, right? Because not only are you seeing the tissue on top, right, the scar, you're not seeing how deep that scar can go. So getting all of that moving can help with the mobility in the abdomen and in the pelvis. What I find is that this part is actually really disconnected from orthopedic physical therapy. So a majority of my career, I was mainly treating back pain, neck pain, shoulder pain, right? I treated the pelvis, but externally, but not to the degree, the way that I'm treating now, specifically with pelvic floor dysfunction. But for some reason, the entire abdomen is missed in orthopedic physical therapy. I don't know why. It's not really treated in school. It's more of a continuing education aspect, and that tends to be more with pelvic floor. So it's not as much with orthopedics. One of the things that I hope and I see in the future is that more pelvic floor physical therapists have an orthopedic background. That means they know how to treat knee pain. They know how to treat back pain. It's not, oh, you go to this PT for this and you go to this PT for that. The reality is physical therapist as a whole, we know how the body moves. We know how to assess these different things. So it's important that everything's being looked at as a whole. But I do hope that gradually with time, we get more orthopedic training with people's pelvic floor training as well. But those are a lot of the things to look at and assess and see what's going on, right? Those are the physical components. Then the emotional and psychological components come in, right? Is there a history of trauma, right? There's unfortunately a significant history of sexual trauma in women. We tend to treat people as if they've had trauma, but maybe don't know, because sometimes people don't know. So like I've mentioned before, the internal assessment, we get a verbal and written consent, and people have every right to remove that consent if that's something they want to do. They have every right to avoid that if that's what they want to do, because there's still a lot we can learn through your history and how you're feeling, and then everything externally that we just chatted about. So there's that whole aspect. And then with that, the body tends to act more visceral in a sense of it tends to hold more tension, right? So when we have complex trauma or we have complex PTSD or any bad experience sexually or sexual abuse, you name it, the body tends to be more reactive because it's trying to protect itself. This is our human and biological instincts protecting us. So what we can do is to help that person learn about their body in a safe space that helps them feel most comfortable. So your physical therapist should be able to talk with you and help you navigate your pelvic floor dysfunction with the history of trauma. And doesn't mean we're not psychotherapists. So it does mean that you may need to work with a psychotherapist to help you with the different things that may come up as you start reincorporating your body into healing, right? And so that is a big component of what I found helpful with people that have had sexual trauma. The other aspect is lifestyle. If somebody is constantly stressed, what I'll find most commonly, especially in women, is the feeling bad for saying no, a decrease in boundaries, overworking to the point where we're fatigued and have no energy for anybody else. This can cause the nervous system fight or flight response to stay active, right? So it constantly thinks you're in the state of stress. So what happens is your body stays in this contracted state. This can affect gut healing. This can affect your pelvic floor because it's tight. It can affect a variety of different areas. So this is also why if we just do internal assessments or treatments and we don't talk about lifestyle, you could be doing that pelvic floor physical therapy all day, every day for the rest of your life. And that isn't necessarily helpful either. So looking at that component, other different factors as too, race, it can be race, sex, sexuality, it can be, living through constant biases day in and day out. We do know that people of color, especially Black women, tend to be more in a fight or flight state because of constant stressors in their day to day due to judgment or intrinsic biases that are affecting people's interpretation of somebody else or how they act around somebody else. All of these things can affect somebody's mental and physical health. So looking at all of these things, also, does this person have a partner? Do they not? What's their home life like? Do they have support? Do they not? Because all of this is going to give you a significant amount of information on what's going on, right? If you know you're working with a single mom and she has 3 kids and she's working 2 full-time jobs, okay, what can we do to incorporate her to be able to do stuff throughout the day so she doesn't have to set aside time, right? Or what is something smaller that she can do to help her get the maximum improvement for the time that she has? Sure, I'm sure she would love to be, doing all these different exercises day in, day out. But the reality is that is not her current life. So how can you meet that person with where they're at? So that's what we'll look at from that perspective as well. So here are a few more questions that people have is, number 1, should I shave? It doesn't matter. It does not matter. It's not going to change how we see you, how we perceive you, what's going on. We can still see everything that we need to see. The hair tends to be on the outside of the labia, so we can still see the tissues fine. It's not a big deal. So there's no need to apologize if you did not shave. Number 2, should I still go if I'm on my period? Yes, it just depends, right? If you don't feel comfortable with an internal assessment, then A, you don't have to do it. And B, if you're on your period and you want to see what's going on around the vulva or vagina, usually I recommend people just not do it on their first day of their period, just because it can tend to be more crampy and a heavier flow, but that's totally up to that person. The times where an internal assessment is not recommended is going to be when there's an active infection. So if there's an active yeast infection, UTI, bacterial vaginosis, those are some common things. If you have an STI, so a sexually transmitted infection, and you have a breakout, that's a time to avoid it as well. Those are some of the bigger components around when you may want to avoid an internal assessment. Now, there is debate on whether or not there should be an internal assessment with people who are pregnant. There's debate back and forth. Some people say no, some people say yes. But generally speaking, if you are a low-risk pregnancy and after 12 weeks, it can be safe, right? But there's no guarantee. That person, if they're still having penetrative sex, then they're likely fine, right? But I would say in the United States, PTs tend to be more cautious with this. If that's the case, it may be that their OB just sends approval for that, right? So if somebody is a high risk pregnancy and they're, under 12 weeks or they've had complications in the past with previous pregnancies, that might be something to avoid and or talk to their OBGYN. So there's a lot of different things. And overall, it really just depends on you, how you feel with that particular provider. Do they make you feel safe? Do they make you feel comfortable? Excuse me, you can't make somebody feel any way, but do they set the environment to be comfortable, to be, excuse me, to be sensitive to trauma and trauma informed? Do they listen to what they're saying? Are they looking you as a whole? Are they looking at your entire body, how you're moving, and addressing why you're here in the first place? And if all of those are getting answered and you feel yourself getting better, you're likely in the right place. All right. So for some reason, my podcast cut out and I'm redoing the ending here. So let me know if you guys have any questions or if there are any particular topics that you want to go over. Feel free to email them to me at drmary@resilient-rx.com. Would be happy to answer them and help you out. So hope you all have a great day and thank you for listening.